Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Welcome to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we are talking all about ovarian failure, perimenopause, menopause, low ovarian reserve, what's the difference, and what you should really understand about your hormones as you are getting older, regardless if you're trying to conceive or not. I just want to start by saying a huge thank you to everybody for being here and supporting the podcast. I want you to know that we've got some really exciting things coming soon, so please check out the website at nataliecrawfordmd.com. On the website, there's a resources page where you can search for topic information. You can find information out about the Enhance Your Natural Fertility course and the IVF course, which is really valuable information on lifestyle, fertility, IVF and embryo transfer protocols, and we do have a course community for the Enhance Your Natural Fertility course. And you can also sign up for the newsletter. The newsletter is at nataliecrawfordmd.com/newsletter. Weekly newsletter are some of my favorite anti-inflammatory or low inflammation food recipes, favorite things, updates. You'll also get access to the TTC Starter Guide about cycle tracking and my top lifestyle tips. And we have a lot of exciting newsletter content coming up as we get closer to the launch of Balancing Act, which is my new fertility book. So very excited to be bringing all this information, and honestly, none of it would exist without all of you. So thank you so much. At the end of every episode, I answer a few of your questions. You can ask these questions at nataliecrawfordmd on Instagram on Monday. These questions will be answered on Instagram, on the podcast, and in the newsletter. You can also call and leave a voicemail. The voicemail number is 657-229-3672. Again, this is 657-229-3672. All right, we're going to dive in and talk about the ovaries and hormone production. And this is some of my favorite information, just how fascinating it is, everything we know about our ovaries and how they make hormones and how they respond to the brain signals and the world around us. But the truth is, if you are born with ovaries, they're going to go into ovarian failure. For some people, this actually happens before they ever start making any hormones. This is a cause of primary amenorrhea, and this is a circumstance where hormone replacement, I have started it on young women as young as age 16 when they've come into my office, and we found out that they're in ovarian failure. I've had patients in their 20s and 30s go into ovarian failure, of course, as we get older. But menopause, officially, the time period when you're past the point of ovarian function, it's going to happen to everybody with ovaries, and we're all on different timelines. There's some things that might accelerate it or give you an increased risk, and some things that might improve your symptoms. There's warning signs that a lot of people are not aware of, and there's a huge impact on what this can mean for your fertility, especially if it's happening to you very early. Some of these definitions really do get hazy, and it leads to a lot of confusion in a lot of people. The take-home message is estrogen is vitally important to the female body. It's important to your brain, your bones, your heart, your quality of life, your sex drive, just how your cells function. And in fact, when you stop making estrogen and progesterone, your body has a lot more inflammation. And that is a driver for some of the symptoms we see. That's an opportunity for improvement, and why some lifestyle factors or alternative treatments that are not hormones can help. But nothing is as powerful as actually replacing hormones if you're deficient in them. And this has been long confusing because the community on hormones, the medical community, has really taken a big shift. And I think it's important to understand where that comes from and where that leads us. And even my own patients so often come into the office and say, well, I don't want to be on hormones at all. And I think it's because the word hormone just carries a lot of negative connotation when it shouldn't. Our body makes hormones every day, a variety of different types of hormones. Hormones are the communication system of our body. It's how one part is talking to the other. Hormones respond and react to what other parts of the body are doing. And some hormones people have no problem taking. For example, when your thyroid gland doesn't make thyroid hormone very well, and you have hypothyroidism or subclinical hypothyroidism, people have no problem getting on thyroid medication. But for some reason, when it comes to our sex hormones, our reproductive hormones, it all is a lot more controversial. And I think it's because for so long there's stigma and we didn't talk about how our ovaries worked normally, and it led to a lot of confusion. The way I like to think about this, you've been here, you've heard it, is that I like to imagine inside your ovary is a vault where all your eggs are kept. You are born with all the eggs you're ever going to have. I can't even wrap my brain around the fact that some people are online saying that that's a false statement. You actually lose the vast majority of your eggs from the time period of being a 20-week baby, so 5 months old inside your mother's womb, until when you are actually term and your mom gives birth. You have 6 to 7 million eggs at the time you're about a 5-month-old baby inside your mom. At the time you're born, you have about 1 to 2 million. Think about that. That's a huge drop. At the time you start puberty, you have 500,000. So you lost the second biggest chunk before you ever had a period. At the time you're 37, you now have about 25,000 eggs left. And at the time you go into menopause, which the average age is 51 years old, you are going to have less than 1,000 total eggs. That becomes the place where your ovaries really are in failure and they stop responding. You're only going to ovulate about 400 to 500 eggs total in a lifetime, and that's if you're not preventing ovulation. A very important concept, and helps understand why these numbers change, is that from the eggs inside that vault, you lose a group of them every single month, no matter what, no matter what. The size of that group is proportional to how many eggs are inside. Meaning, when you had more eggs, when you were that bitty baby, you had more eggs being sent out of the vault every month. The vault was too crowded, didn't want to be that crowded, it sent out more eggs. As you started to have less eggs inside because it was sending out more, it now is starting to send out less because it's not as crowded. And as it starts to get to those low numbers, it sends out even fewer. And so imagine the vault is the storage facility and the keeper of the vault is directing out a different number based on how crowded or empty it is. So more eggs outside the vault in a given month when you have more eggs, fewer eggs when there's less. That's important because that we can measure. That is considered your ovarian reserve. How many eggs do you have left? And the way that we check ovarian reserve is by measuring your AMH, which is a blood test, or by measuring your antral follicle count, which is an ultrasound determination. Checking your FSH and your estradiol is checking the communication system between the brain and the ovary. And it does give us valuable information, but it's not answering the question, how many eggs do you have? When it comes to how many eggs that you have, all of the eggs outside the vault grow inside a fluid-filled structure called a follicle. In the context of a normal cycle, once you get to puberty, the brain starts sending out follicle-stimulating hormone, or FSH. FSH gets the follicle to grow. As the follicle grows, it makes estrogen. Yay, your body's favorite hormone. This is the follicular phase. Estrogen is going to give you energy, help you concentrate. You're going to have a higher sex drive, feel more like yourself. Then you're going to ovulate, and that follicle is going to reform and become the corpus luteum, which makes progesterone. This is the only way we make progesterone. It is made from the corpus luteum, stimulated from pulses from the brain. And if you get pregnant, the pregnancy hormone HCG, what you test in a pregnancy test, will give a constant stimulus and keep that corpus luteum alive. But in the absence of a pregnancy, the corpus luteum can only live for 2 weeks. It dies, progesterone and estrogen drop, you get a period, and a new group of eggs is available to start to respond and grow for a new month. All the eggs that you didn't release, that didn't ovulate, they die. So what's been sent out of the vault is done. Think about this all those months before you ever started your period. So you are now a baby to age 13. I started my period on my 13th birthday. So all of those years, I would have a group of eggs coming out of my vault. What happens is that until you start puberty, your brain is not sending out FSH and LH, the hormones that are controlling ovulation and therefore estrogen progesterone production. So you don't have any estrogen or progesterone. Your brain's not sending out any signals. So the eggs come out of the vault. There's no signal. They all die. Next month, another group. When puberty actually starts, that's the brain turning on. That's what puberty is. Brain turns on, starts sending out FSH. Ovaries start growing a little bit of follicles, making some estrogen, but nothing's mature enough to actually get to ovulation. And that's why we see a couple of years of estrogen slow development, allowing you to get some breast budding, some growth before your periods actually start. So from the onset of having breast development to when you'll see a period tends to be about 2 years. And for girls who went into ovarian failure before they ever had a period before puberty started, this is going to be the case where they may never have breast development. And that's a very specific scenario because you have to replace them with estrogen alone to replicate those couple of years before you add in progesterone. Otherwise, you'll actually get a birth defect of the breast called tubular breast that can be very hard to surgically correct. The reason why it's really important to understand that your body is losing these eggs regardless is because even if you're on birth control pills, even if you get pregnant, if you breastfeed, even if you go through IVF and we take all of those eggs out in 1 month, we're not changing what was going to happen. Those eggs were out of the vault and nobody ovulated. That's the difference. Now, when we're trying to evaluate how many eggs you have, and this is called your ovarian reserve with the AMH and the ultrasound, we're getting a 1 month's glimpse. AMH is a test that is telling us how much AMH, anti-Mullerian hormone, is being made from the cells that surround the follicles. So when you have a higher egg count in the vault, more follicles come out, there's more granulosa cells surrounding them, making more AMH. As your egg count gets lower, AMH gets lower and lower and lower. Your AMH will get to an undetectable level. So when you're out of eggs, when there's no follicles, AMH will be 0. Counting the follicles outside the vault is an antral follicle count. And that is what it seems. I do an ultrasound, I look, I count follicles. This is a 1 month assessment. It's a surrogate marker for what's inside the vault. Your body's not perfect. Month to month, it can change. I like to think about AMH and antral follicle count as giving me a category. Are you above average? Are you average? Are you a little low? Are you very low? Is this critically low? And that's helping me counsel you and have a big picture of what's going on. If we want to take a minute and think about official terminology, because this can all be confusing. Premature ovarian insufficiency is the fancy word for premature menopause. That used to be ovarian failure, but insufficiency is a more accurate word. Your ovaries ran out of eggs, stopped responding before age 40. Average age of menopause, again, is 51. Perimenopause is the transition from a regular ovulatory state into menopause. So menopause is now defined as 12 months of not having a period and now having hormones consistent with ovarian failure. So that's a time, that's a moment in time, 12 months. Before that, you're in perimenopause, and often perimenopause usually lasts 4 to 5 years. It can be 2 to 10 years. And what makes it even more confusing is that if you're coming off of hormonal contraception or hormones or you have certain surgeries, you might not know when some of these transitions happen. But in the perimenopausal time frame, how I like to think about it is that your egg count is now getting so low, the normal brain-ovary connection system is starting to not respond correctly. And this is important because some people will say, we have no clinical signs that you're going to go into menopause or you're going to go into ovarian failure. And that's not true. Now, not everybody has them, but certainly we can. As the eggs get lower, as you have fewer eggs inside your vault, your brain sends out a hormone called FSH, or follicle stimulating hormone, and I like to think about FSH as food for the eggs. So if FSH comes from the brain, its job is to get one follicle to grow. And as that follicle starts growing, it makes estrogen, which tells the brain, we're good, we are growing a follicle. The entire job of FSH is to get our body to make estrogen. When your estrogen levels drop, the brain kicks out FSH again, like, oh, please, we'd like more estrogen. When you have less eggs, the brain has no idea. So we think about the brain as being a computer and knowing what's going on in our whole body. It is not the case, and I use the bad analogy like your brain and your ovaries are best friends in different states well before FaceTime existed. They only text each other. So the brain only knows whatever the ovary's telling it. And the brain doesn't interpret AMH. We see a very specific change in hormone pattern as that egg count gets lower and lower. So egg count's getting lower, we could see that on ultrasound. Egg count's getting lower, we could see that with an AMH. If I think about your period, first thing that happens, brain sends out normal amount of FSH. But boom, there's not as many eggs. Not as many follicles. So that FSH is a stronger signal to one single egg, and an egg starts growing faster. So checking early part of the follicular phase, day 2, 3, or 4 labs, and seeing a normal FSH and a high estrogen, I'm growing an egg too fast, is a sign that there's less inside the vault. What happens clinically, or what you might notice, is your periods are suddenly closer together. They used to be further apart. They used to be 28, 29 days. And the classic story is a patient will tell me, my periods were always 28, 30 days, but gosh, the past year or so, they've been closer to 25 days. That can be a sign of perimenopause, that there's less eggs inside that vault, and now our body is responding by ovulating faster. In this earliest stage, you're still making estrogen the majority of the time. You likely don't have a lot of the other classic menopause symptoms that are associated with being a low estrogen state. But as the eggs start getting less, the brain will send out FSH, and it's not going to be strong enough to get any egg to grow. The ovaries start getting stubborn as there's less eggs. They don't really want to let one grow and ovulate now. And now the brain has to come out and send out more FSH to get the same job done. So now we're starting to see higher FSH values and lower estrogen as we're getting further into the menopausal transition. When this happens, what we often now see is your periods are starting to space out. That stubborn ovary is not going to grow an egg until that FSH signal gets really high. So now what has happened is you went from a regular cyclic pattern to the next stage where your follicular phase is shortening, you're growing an egg, you're ovulating sooner, and your periods are closer together. Now you're ovulating later. It's taking longer to get an egg to respond. And now you're starting to have cycles lengthen/skip months and have irregular periods. And this is typically when you really start to have the red flag, because now in that time period before the egg starts growing and making estrogen, you're starting to have low estrogen moments. So now you're starting to have some of the low estrogen symptoms potentially. And because our fat cells make estrogen too, a lot of times we see this as a more profound change in people who have less overall body fat. But what starts to happen as your estrogen is lower is you might start to experience fatigue, brain fog, difficulty concentrating, insomnia, difficulty falling asleep or staying asleep, low sex drive, vaginal dryness or more pain with intercourse. You're going to start noticing that you might gain weight and you don't have the same metabolic capacity as you used to have. We also see hair loss, just generalized pain or joint pain, GI changes, higher rates of mood disorders, depression, and anxiety. And some of these may come and go, and they're worse with some of these low estrogen moments. And that makes it really hard, and we often gaslight ourselves. As the periods space out more and more, these are going to get worse. And then eventually in menopause, when you have no estrogen at all and you haven't for a period of time, now you have these very low estrogen symptoms. And then postmenopause is the time period which you're after, right? If menopause is a day, menopause is the moment you reached your 12-month anniversary of not having periods, and your FSH level, if we drew labs, is going to be more than 40, and your estrogen is going to be low because your brain is giving everything it has to try to get the ovary to respond, and the ovary has nothing left to give. However, I really do see women on an earlier spectrum who thought there was no chance that this could happen to them, that they could go into ovarian failure or menopause early, and they are just very taken aback by it. I think it's very important to understand that's why we say the menstrual cycle is a vital sign. That's why if you're on hormones, it's fine. Hormones for contraception, like an IUD or a birth control. Remember, the birth control pill is giving you back estrogen and progesterone. A different type of estrogen, so our blood tests aren't going to recognize it, but the brain does. But if you have an IUD and you haven't had periods for a long time, many people with an IUD still actually ovulate and are making estrogen. So a huge thing I see in some of my patients and my peers is that you have an IUD in place, you're happy, you don't care about having a period, but now you're not feeling good. And you're going through this menopausal transition, but you've lost any of the clinical clues because you don't have a period to track. So thinking about how old you are, some of these other signs, that can help you understand what may be going on. When you still want to get pregnant and you have a low ovarian reserve, as I said, I've had patients in their teens, in their 20s, and their 30s. I think it's really important to think about why you might have early menopause or a very low AMH. What we're trying to do is encourage people to understand their bodies, their periods, encourage testing of ovarian reserve earlier, even though ACOG says don't do it, even though there's newer evidence showing that having a low AMH is associated with a longer time to pregnancy. And I think a lot of the overarching connecting factor for why is that at some point it is going to impact your ovulatory pattern, and that's going to make it harder to get pregnant. And it begs the question of why? What is underlying? What is causing this? The easiest, simplest rule of thumb is that when you're under age 40, your AMH should be over 1. Really, the younger you are, the higher it should be. So in my patients who are under age 35, I want to see an AMH that's between 2 to 4. If you're between 35 to 40, then I want to see usually 1 to 3. But if your AMH is 1.0 and you're 29, it's low. If your AMH is 0.79 and you're 37, it's low. Why? Is that an accurate test? Some things can influence AMH. Is it something you're doing? Smoking cigarettes can deplete your egg count. That cigarette smoke gets in that vault, kills the eggs. You actually will run out of eggs faster if you smoke cigarettes. Chemotherapy depletes your eggs. Yes, 20% of patients might come out of chemotherapy already in menopause. The others who don't, who come out still with eggs remaining, have a shorter timeline. They still had eggs that were destroyed. And so they're on a pathway to still having an earlier menopause than their peers the majority of the time. Autoimmune disease can drop your egg count. It's one of the top causes of premature ovarian insufficiency. Having endometriosis is associated with having diminished ovarian reserve, which is a very low AMH, and therefore having a pathway towards higher rates of infertility and a harder time getting pregnant and earlier menopause. Surgical removal of an ovary, surgical removal of ovarian cysts, that can damage the remaining egg count. There's genetic causes. If your mom went into early menopause, you have a higher rate of going into earlier menopause. There can be karyotype abnormalities. There can be abnormalities on the X chromosome that you can inherit and you could pass on to your kids. So you can see that understanding the why is important. Going into early menopause, having diminished ovarian reserve, premature ovarian insufficiency, these things can play a huge impact on your life, your quality of life. It's important, especially if you go into early menopause, to replace the body with estrogen. And this is one thing I'll tell patients all the time. Hey, your estrogen low, that's causing a lot of these symptoms. Getting pregnant is a goal. We're going to see if that's possible. But at the end of the day, we need to give you estrogen because your body needs it. There was huge controversy on giving people postmenopausal estrogen and progesterone from the Women's Health Initiative. And people who are fantastic menopause specialists like Dr. Mary Claire Haver have gone into this in depth, and you can check out some of her content on the Pause Life. But the take-home message is that newer analysis of the data confirmed what many of us in women's health have been feeling, is that women should be started on hormone replacement therapy if they're having symptoms, that it improves their longevity and their quality of life. And so if you get an answer that says no, please consider other opinions, talk to other doctors, especially if you're young. Even if you're going through menopause at the natural age, I think most women will benefit from hormone therapy and they should be on it. It's going to be the rare exception the other way. But if you're younger and you're going through this early, it is so important. Your lifespan, your health span, they depend on it. One important factor to understand is that when you first start hormone therapy, namely it's estrogen, and you have to add back progesterone at a variety of different intervals pending your preference, you can still actually ovulate. So especially if you're young. If you are in premature ovarian insufficiency, I have had a patient where I have tried to get her eggs to grow with IVF. And in IVF, we give FSH to get the eggs to grow. So if your FSH is already through the roof and your eggs are not responding, your ovaries are not responding, I have nothing I can do. And a lot of our protocols try to give you medication like estrogen and see if we can drop your FSH and then get the ovaries to respond. But it doesn't always happen. But estrogen alone is not birth control in this context, where you're just replacing what your body should normally make. And after your brain's seen that for a while, your FSH may drop and then it may rise again. And that might get an extra egg to kind of randomly come out of the vault. And I've had a few patients get pregnant that way, and every fertility doctor will tell you the same thing. And so even if you have a patient who wants to get pregnant and they're super young and they can't respond to any IVF treatment, often the best option for them is donor eggs. And I tell them that. But I also say, hey, you could try just estrogen for a while. If we're okay giving it some time, understanding that donor egg may be in our future, we could try some hormone replacement. And if we're having unprotected sex, you might be able to get pregnant. Same, if you're not wanting to be pregnant, estrogen alone is not birth control. So you might want to consider adding in an IUD or daily progesterone or some other way so that you're also preventing ovulation or preventing pregnancy if you don't want to be pregnant. The age which you are and how many eggs you have left is a big determinant in what fertility treatments might be available for you if you're still wanting to add to your family. Younger and more eggs is always better, but that's not always the luxury that we have. And that's why having an honest discussion and really there can be some urgency to what you're able to accomplish before the light switch is turned, meaning at some point your ovary might respond to me when your AMH is undetectable, and in a few months it might not. So it can feel like a lot of pressure, and that's why understanding what's going to happen in this change and the warning signs for it so that you can intervene becomes extra important. When you should start hormone therapy is something that we don't have the answer for, but I'm of the opinion if your periods are irregular, your hormones are not normal, and replacing those hormones is going to make you feel better. I'm a fan of getting people on hormone replacement therapy at an earlier age so that we know we're not getting into those really low estrogen periods of time and having some of these side effects develop. It's really important to see somebody who knows what they're doing. So you can find somebody who's NAMS certified, which is the North American Menopause Society. You really need to be wary of people who are talking about Dutch testing or replacing a variety of hormones at one time. Testosterone is a complicated decision. You should not be on testosterone if you're trying to get pregnant, period, the end. That's a post-menopause situation only. If you are trying to get pregnant, you should not be on testosterone. If you still want the chance to get pregnant, you should not have pellets placed. So there's some nuance to this. And unfortunately, when it comes to the hormone space, because so many traditional practitioners just said no, no, no after the WHI came out, it led to a lot of distrust and gaslighting. And then women were seeking out other options. And some of those are great alternative options and practitioners who really have done a great job at being menopause and hormone advocates, even if they're not a MD or a DO. But there are predatory people that are ordering expensive tests, misunderstanding them, putting people on the wrong hormones at the wrong time, and really making you feel worse. So I think it's important to have the full picture here and make sure that you get all the information you can. If you have somebody who is dismissing your symptoms, go see somebody else. The end. There's enough of us now. We're old enough. We're going through it to be your advocate. But don't gaslight yourself. Understand your periods of vital sign. Understand what the signs of having those hormone changes can be. Are you having those low estrogen cyclic time periods? Are your cycles lengthening? Have you not had a period in a while? Do you have all of these symptoms? And be able to understand your own personal risk about hormones. And I think for the vast majority of people, estrogen replacement after ovarian failure is necessary, and it's going to help you live your healthiest and your best life. Again, the vast majority of my expertise is in ovarian function when it comes to your hormones and fertility. I definitely see people with early ovarian failure and diagnose them. I see people at the perimenopausal and the menopausal transition. I don't just manage hormones after the fact, but there's so many great people who do. There's so many who are ready to be your advocate. And I'll give another plug for Dr. Mary Claire Haber and her book, The New Menopause. I'm a huge fan. I'm going to answer a few of your fertility questions. These are the ones that you ask on Monday at Natalie Crawford, MD. How can I increase my chances of getting pregnant if I am in the early stages of menopause? That's a timely question. So potentially estrogen replacement. Remember, we don't want you on unopposed estrogen for more than a few months, so that's a nuanced discussion. Potentially ovulation induction medications or even IVF, gonadotropins, depending on what stage you're at. Ultimately, remember that menopause and perimenopause is a high inflammatory state as your body is losing some of the estrogen and progesterone. And so really paying attention to your lifestyle and making sure that you are decreasing inflammation as much as you can is going to be very important. Getting an evaluation ASAP from a fertility clinic, anatomy, sperm, important. And understanding that if you're truly in ovarian failure, if it's not early menopause, but it's menopause, and your ovaries will not respond to hormones, you can still carry a baby, your uterus will still function, but you will need donor egg or donor embryo to get there. I don't have periods and was told I have hypothalamic amenorrhea, but no testing was done. Should I ask for more tests? This is actually very important because the symptoms, the outward symptoms of your brain not sending out any FSH, low FSH, and your brain sending out all the FSH that it has, but your ovaries not responding, are the same. Both of the symptoms that you're going to get from these two scenarios are because your body's not making estrogen. So the low estrogen symptoms is what makes you feel all the symptoms I rattled off. And in some young patients, somebody will look at a thin, younger woman who's not having periods and say, "You're not eating enough. Stop running, eat more. That's the problem." And it might be. Perimenopause, early menopause should never be just verbally given to you without an evaluation because thyroid abnormalities, prolactin abnormalities, hypothalamic amenorrhea, PCOS, some of these things can masquerade and you need to check hormones in order to know. But for hypothalamic amenorrhea, I've had patients diagnosed with that, told they need to make lifestyle changes, still estrogen low, and then when they come to me, we find out, well, they're actually estrogen low because they went into early ovarian failure. And it's very frustrating because they have felt terrible for so long, or potentially intervening earlier could have helped them. So understand that if somebody's giving you you run too much, you work out too much, you're not eating enough, you're too thin, those might be true, but that's a diagnosis of exclusion. You've ruled out the other things first, and you should advocate for hormones. The minimum hormone testing that we want in this scenario is FSH, estradiol, TSH, and prolactin. That's going to be the minimum to get you started. I like to add in an AMH in that scenario if you're younger and you want to still have a family. Can I still get pregnant with low hormones? And that's a good question and just has a basic, I don't know. It depends on what's low and why is it low and when's it being checked. Throughout the course of a normal, regular cycle, you might have low hormones at a variety of very normal times. So it's really important to understand what are we seeing clinically? Are your periods regular? Are you having spotting? Are they changing? And when did we check the hormones and what is normal and what is abnormal? There are times when maybe you could get pregnant, but you're not ovulating right, and we fix your ovulatory pattern, we can help you. There might be times where you're in ovarian failure, there's nothing we can do. Or maybe you do have hypothalamic amenorrhea, and we need to give you FSH to help you ovulate. So understanding, well, what hormone is low, and is it normal to be low or not, and what should it be, and when was it tested? And so this is a more nuanced discussion, and you should feel comfortable asking these questions to your doctor. Well, was that low? I saw it was low. Was that right? What should it have been that day? Well, why are my periods still irregular if this is normal? What other testing should we do, or what should we do next? Remember that hormones is a blanket term that is hard. It's very hard if you go to a doctor and you say, I want my hormones checked, because what does that mean? Or I want my hormones balanced. Balanced for when? But you should come armed with what's going on. Hey, my periods have changed from where they used to be. And I now have a really hard time falling asleep. I've gained weight, and I really am having a hard time concentrating, and my hands are numb. Can we evaluate what could be going on? Or now I'm having really long cycles and a lot of spotting, and overall I just have really low energy. I'd like to see if we can find a cause for my change in my periods. And it shouldn't have to be that hard. But the truth is, you've got to give them some history, some change of symptoms. You know your body the best, your doctor doesn't. So you've got to tell them what's different. So don't let a doctor gaslight you. Go see somebody else, but don't gaslight yourself into thinking that this is just normal or you're being crazy, because our hormones are going to change. Everybody is going to go into ovarian failure. And understanding when it's happening to you, what the signs are, and what you should do is only going to improve your life. All right, friends, hope this helped. As always, you can ask questions on Instagram at nataliecrawfordmd. You can check out the YouTube, and I appreciate you so much. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.